I'm pleased to introduce Krissie Guerard, who's the Health Equity Director for the North Dakota Department of Health. Krissie is a graduate of Minnesota State University Moorhead with a Bachelor of Science degree in Community Health and Minnesota State University Mankato with a Master of Science degree in Health Science. Krissie began her public health career with the North Dakota Department of Health Division of Disease Control in August 2006 as the Ryan White HIV Surveillance Coordinator, and then took over as the HIV STD TB Hepatitis Program Manager in May 2007 through 2013. In March, Krissie moved to Minnesota to be the STD HIV TB Section Manager at the Minnesota Department of Health. And we're really glad she came back to North Dakota in August of 2018 in her current role as Health Equity Director. And I can say after being around the health equity and health disparities field for a while, there has been great progress made in the last couple of years, thanks to Krissie's efforts and the ability to devote some more resources to this. So let's get it underway. Take it away, Krissie.
Well, thank you, everybody, and thanks for jumping in on the technology front. And just a forewarning, in this view, I can absolutely not see faces, and I can't see any questions that are coming in. So, Karen, if you can help me with that during the presentation, that would be great. So as Karen said, my name is Krissie Guerard. I am the Health Equity Director for the Department of Health. She also mentioned that I did spend a good portion of my career working with HIV, STDs, and TB. And the reason that I mentioned that is those are three areas where disease disparities are actually fairly great. And I think that really began my career path to health equity. So today we're going to talk a little bit about health equity and equality, the social determinants of health, health and all policies, and then we are going to touch a little bit on what the Health Equity Office has been up to in regards to health equity. I'd also like to say that, you know, this is a big topic and a bigger topic than we have time for today, but my hope is that this might just spark something with you and it will bring on more conversations in the future. So the first definition I have here is, what is health? Well, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease. Seems pretty simple, right? But I like to break it down a little bit. Health is a state of well-being and the capability to function in the face of challenging circumstances. Health is kind of considered a positive concept, and it emphasizes social and personal resources as well as your physical capabilities. So physical health, basically the state of your physical body and how it works, and if it's operating correctly. Mental health is a state of well-being in which an individual realizes their own abilities, they're able to cope with the normal stresses of life, and they can work productively and have a contribution to their communities. Social health really involves one's ability to form those satisfying interpersonal relationships with others. You have the ability to adapt to different social situations and act appropriately in a variety of different settings. Feelings of well-being are fundamental to the overall health of an individual. It helps you successfully overcome difficulties and achieve what you want out of life. Past experiences, attitudes, and outlooks can really impact your well-being, and so can your physical and emotional traumas that you've had from certain situations. So why am I bringing this up in a presentation about health equity? Why is it important? It's important because everybody does not reach the definition of what good health is, and a lot of that has to do with those health disparities and not achieving health equity. So this next busy slide is, I really do like to start off showing a word cloud. And the reason I like to show a word cloud is because when we talk about health equity, we really talk about a lot of terms. Some of these terms are used interchangeably, sometimes they're used wrong, but more than anything, they really play into each other. And this is only the tip of the iceberg on this word cloud. There are probably hundreds of other words that we use when we're talking about health equity, but it can be a lot, and sometimes a little fearful for people to talk about these issues, and a little overwhelming. Some other common terminology when we're talking about health equity work, we talk a lot about race. Race is basically grouping people by skin color. You hear a lot about disproportionately affected populations. We use that a lot at the health department, disproportionate. And all that really means is it's an over or underrepresentation of a group compared to representation in the general population. Isms have become quite popular. Systems of privilege and oppression based on social identities. So we've got sexism, classism, ageism, and 100 other isms that you guys could probably all rattle off at the top of your heads right now as well. So isms have been quite popular with terminology used in health equity work. But today I would really like to focus on two terms, and that's equality and equity. And I think the most important thing to talk about is that equality does not equal equity. I like to use this diagram, and I'm sure most of you have probably actually seen this before, but it's a very easy way of understanding the differences between equality and equity. On the top, it talks about equality. And you've got 4 people of different circumstance or different age, different abilities, and we are treating them equally. So we're giving every one of these individuals the same bike, whether or not it actually works for them. On the bottom, we're treating people a little bit more equitably. So basically, everyone is still getting that bike, but they're getting a bike that actually works for them. So they're able to actually ride the bike. And I think this is an important mindset to keep, just because I think that if we really keep the thought of equity in our minds when we're developing our programs, that we're going to have better success. We're actually going to create those programs based off the needs that actually need to be met. So on the flip side, if we're talking about health equity, you often hear the word health inequity. So health inequities are really just the differences in health status between more and less socially and economically advantaged groups. They can be caused by systematic differences in social conditions and processes that determine health. The important part of this definition is that health inequities are avoidable. They're unjust and they are actionable. And what causes these inequities? What causes the inequities really can come down to the social determinants of health, which we're going to talk about next. But it is important to understand that we have to address health inequities in order to actually achieve health equity. So moving on just to talk a little bit about the social determinants of health. The social determinants of health are the circumstances in which people are born, they grow up, live, work, and age, and the systems that are put into place to address illness. These circumstances can have a tremendous effect on one's health, and they can affect anyone regardless of their age, race, or ethnicity. The social determinants of health are important to understand when we talk about all of these issues on this slide. So economic stability, education, health and healthcare, neighborhood and built environment, and social and community context. So much of who we are is actually defined by these factors. The social determinants of health are an important aspect to consider when we're trying to improve population health, by looking at other factors that actually contribute to the population's health. Each of the areas represented on this slide also represent struggles many in our communities face, and each of these can be a barrier to good health. So to improve a person's health and well-being, we really need to consider these factors to address the social determinants of health. So the interesting part is that only 20% of an individual's health is actually tied to clinical care. So that would be the access to and the quality of healthcare services. 80% of an individual's health is actually tied to physical environment, the social determinants where we live, work, and play, and other behavioral factors, which could be anything from how much exercise you get to smoking. And that 80% can actually be broken down even further. That 40% is actually attributed to our socioeconomic factors, 10% to our physical environment, and 30% to health behaviors. So we know social determinants have a bigger impact on a person's health than clinical care. So we really want to support practices that address these key issues as a part of successful population health strategy. Can you see it and hear it? So I actually have another video. I'm going to start talking a little bit about health and all policies, and I am guessing that I'm going to have technical difficulty again. So I'm just right now because honestly, I'm going to try to share a video right after this, and it might be easier to do it just like this. So thank you all for bearing with me. So health in all policies is a collaborative approach, and it really looks at improving the health of all people by looking at health into decision-making across different sectors and in different policy areas. And it's an approach to address the social determinants of health that are key drivers of health outcomes and health inequities, which we just talked about. So I'm going to try this again, folks, and see if I can get this next video to play. This is a great video that talks about health and all policies, and I love using it because not that I can't sit here and ramble on to you guys about health and all policies, but I think that it's a little bit more entertaining than I am. So I'm going to try this one more time the way they told me to do it. And if that doesn't work, we will go try it the other way. Do you guys
How do
see
you
it?
build a healthy community? It's more than our genes, individual behavior, or even access to healthcare. The environment and play have the greatest impact on our health. To build a healthy community, it all starts with our environment. We need healthy food, clean air and water, parks for recreation and play, safe transportation for people on foot or bicycle, or in cars or transit, tobacco-free places, indoors and out, affordable homes close to.
Okay, it worked. That's very exciting. And I think I've got the slides back to where we were at. So hopefully all is good here. So just to reiterate a little bit of what you saw in that video, I love that video. I think it does a great job explaining what health and all policies means. So just to reiterate what the goal of health and all policies means is we're really making sure that we have the decision makers informed about health and equitability and sustainability consequences for their policy development. And you want to make sure that these players are at the table throughout the policy development instead of afterwards. So if there are ramifications for health, for what policies they're making, they're included in those discussions. It really is a way to identify ways in which decisions in multiple sectors affect health and how better health can support the achievement of goals in multiple sectors. So basically engaging different partners and stakeholders to work together to improve health while advancing other goals. So it might be promoting job creation or economic stability, having transportation access and mobility. Other things might be having a strong agricultural system, environmental sustainability, and educational attainment. And this is nothing new. There has been some really great things from intersectional collaboration. A few of them that you're probably familiar with are restricting tobacco use in workplaces and public spaces, improving sanitation and drinking water quality, reducing domestic violence and drunk driving, and requiring the use of seatbelts and child car seats. So there are many areas where we have actually had great success in cross-sectional working together to address the social determinants of health. And those were just a couple. I'm sure that you can name 100 more. So this next slide is talking about the triple aim of health equity. And this was something that was developed from the Minnesota Department of Health as they were establishing their health equity initiative and their health equity office. And I just like the approach. So I threw the slide in there for your guys' knowledge point. So basically, this is exactly what it says. There's a triple aim to achieve health equity. And the triple aim includes understanding what creates health and expanding that understanding, taking that health and all policies approach, and then also strengthening the capacity of communities to create their own healthy future. So we do need to acknowledge that communities themselves need to be involved in creating policy and systems that improve conditions for their residents. One of the things that I have learned throughout my career, and especially within the last couple of years, and even within the last year through the COVID response, is what works in one community doesn't work in the other, and making assumptions without getting that community support doesn't always work. We also really want to take a broader view of what creates health. We can better understand how policies related to those things we talked about, transportation, housing, education, can actually affect health outcomes. And without that focus on health equity within that approach, you can have some unintended consequences. And then just the overall expansion of understanding what creates health, and that it's more than just medical care, and really just changing that narrative. We want to make sure that we're bringing those new voices to the discussion on how to create optimal health for all. So next, I just want to talk a little bit about what the Health Equity Office is doing and what the goal and the mission is for us. So the Health Equity Office really is working to understand and reduce health disparities among all North Dakotans. The goal is to reduce rates of disease by providing opportunities for interventions and improving access to healthcare. Really looking at how we can ensure all North Dakotans receive that highest quality of care. So I'm going to talk a little bit about our strategic planning and these two big plans that you see on the screen right now. We have two strategic plans moving at the same time. So on the left side, there is a COVID-19 North Dakota Special Populations Plan, and on the right side is just the Health Equity Office's strategic plan. So the reason that there's two different plans is COVID brought a lot of activities as far as health equity, not just within the Health Equity Office, but the other grants received within the department had a specialized focus in health equity. And we realized soon or fast on here as this funding has been coming out that we really needed a place to keep all of those activities in one document to be able to make sure that we could track everything that we needed to. And I should stop and say, if you're interested in really diving deep into these health equity strategic plans, they are on our website. And the last shot I had, my last slide, has the Health Equity Office's website, and you can check them out there. They're quite lengthy, but and if you have any questions about them, you can feel free to reach out to me. But a little bit about what's in that COVID-19 plan. So the immunization grant and the ELC, the EpiLab capacity grant, both had a very large focus on health equity. So within this plan, we have our initiatives, our activities that are working within those grants. And we also just received yesterday, well, starting June 1st, was an actual COVID-19 grant specific to health equity in North Dakota. So those activities are actually in this plan as well already. We do have some general activities, just those regular office kind of hiring activities that are in there, but we also have it broken down into populations. So you will see different activities related to COVID-19 for the African American population, the American Indian population, the New American Foreign-Born Immigrant, or NFI, I will refer to them as, along with persons with disabilities, the aging and elderly population, rural and homeless populations. There's activities related to COVID-19 for all of those special populations in North Dakota. On the right side is the Health Equity Office's just regular strategic plan. Like if COVID wasn't happening, that's the activities that we would really be diving into. We are still diving into those activities. We haven't, I guess, probably gotten in depth with them as much as we would have liked over the past year and a half, but I do think that, I mean, with the COVID-19, we have been able to expand the Health Equity Office and still do a lot even in the midst of this pandemic. A few of the things in that plan that I would like to mention to you guys today that I think you would find interesting or maybe even would like to be involved in is we did start 3 new advisory boards. The New American Foreign-Born and Immigrant, or the NFI Advisory Board, started last year in June, so June of 2020. And that advisory board is for New American Foreign-Born and Immigrant population. We also started a BU, or an LGBTQ2S+ advisory board. They're known as the BU Advisory Board. That board started back in February of 2021. And then the newest board just started 2 months ago, and that's a youth advisory board, and that's made up of youth from 15 to 21 years of age. The purpose for these advisory boards is really bidirectional. So we not only want to hear from them, but we also bring things to them. So if there are things that are happening in their communities that they feel that we need to know, we are hoping that those individuals on those boards are bringing those concerns to us so that we can address their needs. And on the opposite side, I use a very easy example here, but if we had a STD media campaign that we wanted to really speak to the youth population. Well, I don't know about some of you, but I'm not a youth anymore. I'm far from it. And so we would really want to vet that media campaign with that age group. And they would be able to tell us if they think it would really speak to their demographic. So we really use them bidirectionally. You know, we bring things to them and they bring things to us. The other part is we have opened up these advisory boards to other community agencies and other state agencies. So if you have a need where you need to, you know, run something by one of these boards, we are always open to that. And you can just reach out to the Health Equity Office with any of those needs. We've already, for like the NFI advisory board, we've had the Department of Transportation, the Department of Commerce, just to name a couple, already utilize that board. And I'm assuming that the youth board and the BU board will be utilized in the same way. They just haven't been up and running as long and have only had a couple meetings thus far. So that's been really exciting for us. One of the things that we're looking forward to in the future is also doing a tribal health advisory board. We do feel like that is one of the things that is missing. We do have that in our strategic plan and are hoping to work on that very soon. Another very exciting thing is that our health equity website, full of a ton of different resources that you might be interested in, has been updated thanks to one of my public health associates in the health equity office. She gets the big kudos for it. She did an amazing job redoing the health equity website for the department. It has a ton of stuff on there, so feel free to peruse that. It might spark some questions for you. We also just have started a health equity newsletter that began last month. And that's also on the website. So if that's something you're interested in getting a hold of for those resources that are in that newsletter, you can visit the website and you can sign up to get on the list to receive that newsletter as well. We are also working on an L+ or an LGBTQ friendly initiative for healthcare providers. That should be coming soon. And we've done a lot with trainings. We're hoping to increase our training capacity. We are a resource for people. We are a resource for agencies and community-based agencies, state agencies that want presentations or need some education. If you can't find it on our website and you have questions, that's what we're here for. A big part of what was in that strategic plan, or is in that strategic plan as well, was the expansion of the Health Equity Office. That was something that was looked at back in the beginning of 2020. And at this point, in the beginning, it started with just my position. And since then, we have grown to 3 FTEs. We have 2 public health associates from CDC. We have a health equity immunization coordinator for COVID-19. We have a health equity COVID coordinator that's going to take care of doing all of the work with that special populations plan for addressing COVID. We also are hiring 4 tribal health liaisons and a new American foreign-born and immigrant health liaison. So we've got some really exciting things going. Excited for what we can have going on in the future and to expand our strategic plan and to continue to do more. So that is what I have for today. You can see my contact information is there along with our website. Feel free to visit that website. Feel free to reach out with any questions, or if you think there's something missing from that website, we're always game to hear for some feedback. So I am going to go ahead and stop sharing.
Thank you so much, Krissie. We're always excited when we have some technology wins on the first day of our conference here. So thank you, everyone, and Krissie for your patience. Thank you to Krissie for your presentation. I neglected to share at the beginning of the presentation that Krissie did not share any disclosures, that she did not include any discussion of commercial products, services, discussion of off-label or investigational uses of product or services, and did not include trade names. That's our official message to share. Krissie is very approachable and stands ready to help. Please, if you have further questions or ideas or needs after this presentation today, please feel free to reach out to Krissie. The website for the health equity section of the Department of Health is posted in the chat, and also a reminder to complete the post test, especially if you are seeking continuing education.